to our webinar this evening run by North Western Melbourne PHN. We're here for a webinar on a new pathway that's being developed about managing dyspnea in general practice. And my name is Sue Merritt. I'm the manager of the Collaborative, the organisation that's been working on this pathway, or group of organisations, I should say. Before we begin, North Western Melbourne Primary Health Network would like to acknowledge the peoples of the Kulin Nation as the traditional custodians of the land on which we're meeting today. We recognise their continuing connection to the land, waters and culture, and would like to pay our respects to elders present, past and emerging. A couple of little housekeeping tips before we get into the presentations this evening. All attendees have been automatically placed on mute, and we would ask that you keep your microphone on mute unless there are particular times for questions, and we'll let you know when those times are. There is a chat box that you can write questions in at any stage, and we will be gathering them up to so the presenters can answer those questions at the end of their presentations. So please use the chat box. A note that the session is being recorded, and please ensure your name is correct in the Zoom meeting. It's very easy to change your name using the little dots up the top right-hand corner if you need to. So just briefly, the Collaborative is a partnership between 4 organisations: North Western Melbourne Primary Health Network, Royal Melbourne Hospital, CoHealth and Merry Health. And the work that we do goes across the acute and primary health sectors, aiming to create better pathways for people with complex chronic disease. And this evening we're here to talk about a dyspnea pathway pilot that we have been developing over the last year or so. And we are starting to enrol patients into that pilot from next Monday, the 6th of September, and the pilot will be running for a 1-year period. Well, we hope it will continue, but we have definite commitments to run for at least 1 year. All right, just trying to move on to the next slide. This is just a brief overview of the agenda for you. We've got 3 key presenters this evening talking about the management of exacerbations of heart failure, COPD, and then Dr. Sarah Whitburn is our GP facilitator this evening, and then she'll also take us through an overview of that dyspnea pathway and the GP's role in managing patients in that pathway. And then we'll go to a panel where we've got a few additional participants coming in to talk about different aspects of the pathway, including some of our colleagues from community health and the HARP program who are involved. So without further ado, I'd like to introduce you to Dr. Sarah Whitburn. She's a clinical editor at Eastern Melbourne Primary Health Network, and she's recently updated all the respiratory pathways for Melbourne Health Pathways. She's a GP who's worked in private practice in Balwyn and Rowville, and currently she's a medical educator and clinical doctor at Family Planning Victoria. Sarah has kindly agreed to facilitate the webinar and panel discussion tonight. She's been an integral member of our clinical advisory group that has been developing the dyspnea pathway, and we're very grateful for her for facilitating this evening. And I'll pass you over to Sarah.
Thank you very much, Sue. Well, I'm actually going to introduce Associate Professor James Wong, who's going to give us our first talk about managing exacerbations of heart failure in general practice. Associate Professor James Wong is the Director of the Echocardiography Laboratory, heart failure specialist and supervisor of cardiology advanced trainees at the Royal Melbourne Hospital. He graduated from the University of Melbourne in 1985 with honours in medicine and surgery. He completed his residency and training in cardiology at the Royal Melbourne Hospital, after which he was awarded a National Heart Foundation Scholarship to complete his PhD in vascular biology at the Baker Medical Research Institute. Postgraduate training was obtained in an advanced cardiac imaging fellowship in the cardiovascular imaging laboratory at the Cleveland Clinic Foundation in Ohio, USA. More recently, he was part of the writing group for the 2018 National Heart Foundation Heart Failure Guidelines. And I'm going to hand over to you now, James. Thank you.
Okay, thank you so much for that. I'm just going to share my screen, and hopefully this is all going to work pretty well. So can you see this all well over there?
Yes, we can. Thanks very much, James.
Great. Thank you so much, Sarah. This evening, we're just going to talk about the management of exacerbation of congestive heart failure in the general practice world. And I guess it's going to be, we're just trying to bring the whole thing together in a linked, sort of pattern. I think it's what we're actually trying to achieve here tonight is basically to link the actual care that's delivered by GPs and also by hospitals in a more cohesive form here. So I just want to allude back to the Heart Foundation guidelines, which we were able to help write back in 2018. These were long time coming because the previous ones to that was written in 2011. So there had been a lot of changes made in that time period. So it's written in a way that it kind of looks like a textbook and it feels like a textbook, and it actually has ways of helping you to guide as to how you diagnose heart failure, how we view heart failure, and what are the actual treatments which have actually been of proven benefit for their patients to work with. And so it gives us a guide as to exactly why we basically gave some guidelines and some recommendations. So if you do have time, have a flick through that. It's an important piece of document, I think, to help us guide our ways forward in heart failure. So what is heart failure? I mean, there's a lot of ways to define it, but heart failure is a complex clinical syndrome with typical symptoms and signs that generally occur on exertion, but can also occur at rest. It is often secondary to an abnormality in cardiac structure and function that ultimately, when combined, impairs the ability of the heart to fill with blood at normal filling pressures or eject blood sufficient to fulfill the needs of a metabolizing organ. And broadly speaking, we have divided heart failure into two types. One we call heart failure with reduced ejection fraction, where the EF is below 50%, and heart failure with preserved ejection fraction, where the EF is above 50%. And I just want to remind you that the ejection fraction is really the proportion of blood that gets ejected out of the heart per squeeze. So in terms of defining heart failure, it's not enough to have a problem on the echocardiograms showing that the left ventricular systolic function is abnormal. You need to have symptoms and signs, because therefore heart failure is actually a clinical diagnosis which is supported by investigations like echo to then further define if it's a heart failure due to reduced or heart failure with preserved ejection fraction. I won't go through the nuances about this so far as to how we go down which pathway, but I just want to broaden that topic up and divide the two types of heart failure that we do have. And you'll probably understand that we've been talking about heart failure with reduced ejection fraction for many years, and this entity of heart failure with preserved ejection fraction has been possibly an entity which is increasingly well known and better known, and you'll probably find that over time, there's a lot more people presenting to you with heart failure with preserved ejection fraction. I want to just quickly look, provide you with a diagnostic workup slide, which is actually present in the heart failure guidelines. If you want to look at this, it's I don't want to put this thing as an oh my God slide, that there's so many things going on here, but I think it sort of gives us an idea of a systematic approach as to how we diagnose heart failure, how we confirm the actual diagnosis, and how we start to initiate the treatment for heart failure. We understand that probably 95% of heart failure is in the community, And amongst the actual general practice population, it's out there in big numbers. And we only see the actual tip of the iceberg that come into hospital, and they're the ones that are quite sick, as you can understand. But most of the management of heart failure is actually community-based. In a background snapshot of what was happening with heart failure in Australia back in 2017, we noted that within 5 years of a hospital admission for heart failure, half of the patients would have died. About 1/3 of surviving patients will be readmitted for some reason within 30 days of an initial heart failure admission. And surviving patients will experience, on average, 3 or more hospital readmissions for any reason with 1 year after an initial heart failure admission. So basically, a heart failure admission is really the sign of bad things to come. And the idea is that we need to get the patients better, well, and back into the community, and hopefully not allow them to actually fall back into place in the hospital too soon. So our goals of therapy of heart failure is obviously to make people feel better, to improve their symptoms, or to slow the rate at which things actually get worse for them. We like to keep people out of hospital because, as you know, it does inconvenience the person, inconveniences the family to a huge degree, and it is very costly to the actual hospital itself. We also, if possible, increase life expectancy, preventing sudden death or progressive pump failure or heart failure, which are the actual 2 modes of death in this group of patients. So then the question's asked, how do we deliver a uniform multidisciplinary care to everyone with heart failure? And I guess in one brief of mine, I had to think about ways of actually deploying care of heart failure right across the western side of Victoria. And we know that there are some remote areas in the country, Victoria, where they don't get to see a doctor very much at all, or have very little access to medical therapy or care, unlike what happens in the metropolitan area. So we'd like to actually deliver something that is actually uniform. So we came up with this idea of what the molecule is. And just to remind you, back in the chemistry days, a molecule is an atom or a group of atoms bonded together, representing the smallest fundamental unit of a chemical compound that can take part in a chemical reaction. So let's rearrange the wording a little bit and just make it into the molecule of heart failure care, which is a group of healthcare workers bonded together, representing the smallest fundamental unit, being a heart failure service that can take part in a network of cardiac care. So this really represents the minimum level of care that any patients who are at risk of or who have heart failure already to expect and should have access to all over the country. So this is what this so-called molecule looks like. And you can imagine that we like to work together as a single unit. We like to understand that patients who enter this system can enter via the access of the GP, they can enter via the access of the hospital or the specialist or the emergency department. So once they do enter the actual or attach themselves to this so-called molecule, that all of the actual entities inside the molecule are automatically made available to them. So we hope to then deliver this kind of care to everyone that has heart failure, no matter where they exist or live in country Victoria. One of the things that we talk about is really what happens in hospital, and we try to get them back out to the community in a fairly safe way. We like to basically provide patients with some level of education about the symptoms of heart failure, and they're listed here: the fatigue, the limb or stomach swelling, the palpitations, the weight change, the cough, the breathlessness, or the inability to lie flat, such as orthopnea, or the inability to sleep at nighttime, or waking up halfway through the night, being paroxysmal nocturnal dyspnea. So we also like to make sure that patients are educated about their medicines. We like to ensure that they have a good list of their drugs, get some understanding about what their drugs are all about and how these drugs actually help them out. and they should not be stopped without consultation with their doctor. And we also like to promote the community pharmacists to be involved in this whole process of care, to make sure that they're actually taking the right drugs in the right way and not forgetting to take them at all is a problem as well. We also want to have the healthcare professional review them within 7 days of discharge. And this has been a well-known entity that patients who are seen shortly after discharge from hospital from heart failure have a much better chance of staying out of hospital in the longer term. So this will help to assist the patient and support the person. We like to make these appointments for the patients, if possible, before their discharge, or they have a plan to see their GP at a certain date after their discharge from hospital. We also like to make sure that they bring all their hospital paperwork and the medicines to any of the follow-up appointments, and also to give the patient and their support person contact details in case things do fall apart, to understand who to contact even inside the hospital system if things don't work out very well. Cardiac rehabilitation, physical activity is a very important thing, and this has really been shown after many trials to show that exercise programs and forms of cardiac rehabilitation do improve the quality of life and also reduces hospital admissions. So we basically would like to enroll patients into exercise programs and so-called cardiac rehabilitation programs before they go out the door, and also to involve other management, chronic disease management firms such as HARP and HIP, which you have also been familiar with already before. We like to also give patients a written action plan to emphasize that the early medical review and symptoms worsening can help them keep themselves out of hospital and to reduce the amount of time needed in hospital. And to also discuss and confirm with the patient and the support person, who do they call? Do they call their GP, their community nurse, or 000? These are the kinds of things that I think we'll be talking a bit about down the track this evening. In terms of what happens in the GP practice, we really like to encourage regular reviews and to help support the up-titration of drugs, change them or add to them in any shape or way as possible. And the GP can therefore escalate further care if the patient's condition does worsen. I put this slide up because the four big things that can go wrong that needs effective help in the community in a heart failure patient is congestion, congestion, congestion. And I can't emphasize it any more than that. But the whole idea is to try to get the fluid off them, because really the fluid is their enemy, and it can exist in the belly, the legs, and their arms, and in their lungs, and makes them very, very short of breath. So the key thing is to take that congestion away. So I think we will talk about this in a bit more detail. We'd like to be able to escalate the intensity of care should you feel that that's required. But I think the important thing is to identify what are the signs and symptoms that require that intensity of care to be escalated. So certainly someone who gets short of breath, who have some problems sleeping at nighttime or lying flat, if they've actually increased weight by more than, say, 2 kilograms over 2 days, they get dizzy, they have renal failure, dehydration issues, social risks such as partner supports and so forth, or increased levels of anxiety and depression. I think it's important to recognize these features. And to escalate to a high intensity of care, such as requiring hospitalisation, certainly the patient who is quite short of breath at rest, who has worsening hypoxemia. Some of our patients do have home oximeters as well, so they can understand exactly or confirm with you that things aren't looking great from an oximeter point of view. If they do have high fevers or confusion, they need to go to hospital. If they do have chest pains or tightness in the jaw that's not relieved with anginines or sublingual nitroglycerin spray, they need to go to hospital, as do people with altered mental state, sweating, weakness, fainting, and blood, coughing up blood. So in the last few minutes of this talk, I just want to also allude to the Heart Foundation have some nice guidelines And they do have brochures which the patients can actually download. And in this particular one, there is some important information about dietary guidelines, fluid restrictions, and also areas in the booklet to record their weight, blood pressure, and weights as well. So the action plan for the patient, we like to make sure that all the patients take their medications as instructed. We like them to weigh themselves on discharge and also using the scales at home, measure their fluid intake every day to make sure that they're not going over a certain volume of fluid, understand that certain foods do hide a lot of fluid in it, such as fruits, yogurts, ice cream, jelly, fruit, and such. It's important to include those in your actual calculations to make sure that they know how to call for emergencies and know when to call for emergencies, such as severe breathlessness and blackouts. We also like to have them understand that weight gain over a short period of time really equates to fluid gain. And there's not many things that change that quickly over 2 days. Fluid changes things very quickly. Fat and protein, weight gain doesn't occur that fast. So if it does occur that fast, it's got to be fluid, and it's important to get that fluid out before they swell up to more than, say, 5 or 10 kilograms of fluid overload before they then surface into hospital, which means that they've got to be in hospital for a much, much longer period of time. So they should understand about the issues of worsening breathlessness, swelling of what the abdomen and ankles really mean, and how they actually should recognize these sort of features, and also understand that dehydration is also the enemy as well as in heart failure, because we don't want a situation when they get so dehydrated that they become hypotensive as well. So also to make them understand that what are the other things about heart failure? It's not all about breathlessness. There are things such as walking distance reduction, palpitations, feeling tired, feeling dizziness, lack of appetite. They're the other more subtle things that may change, and it's important to have them recognize that these are in fact heart failure symptoms as well. I use this thing called a 2-to-2 heart failure plan, and it basically means that if a patient increases the weight of 2 kilograms over 2 days, then you basically double their dose of Lasix for a couple of days until their weight drops back down. And sometimes this is enough just to keep them out of hospital and get their fluid volumes down very, very quickly. I just want to talk very briefly about the 5 pillars of the medications that are available to us. The diuretics, which are obviously well known to you, furosemide or the loop diuretics, the thiazide, the MRAs. The ACE inhibitors, the ARBs or the ARNIs, which are the new kid on the block at the moment, beta blockers of Aberdeen, and the new ones are the SGLT2 inhibitors. So these offer prognostically advantageous benefits for the patients. So the only things that don't do it are the furosemides and the bubentinides and the thiazide diuretics. So they take symptoms away of fluid, but they don't make them live longer, but it's there to make them feel better. Also important to understand that we like the up-titration of all of these other drugs because they do enhance the longevity of our patients and also enhance the actual well-being of them in the long term as well. Understanding that the up-titration of heart failure drugs is important, but often limited by what is recognized as being very low blood pressure, low heart rate, renal dysfunction, say high potassium levels or even low sodium levels can be a problem in the long term of up-titrating these drugs. So I might stop there because I think we may run out of time soon, so I'd be happy to address any questions you might have at the moment.
Thank you very much, James. So if anyone has questions, please do put them in the chat. While we're waiting for people to perhaps put a question in the chat, James, I was just wondering, you've mentioned the medications. I just wondering, when you have someone who's got polypharmacy, where you've tried a number of different medications as well as increasing Lasix, you've got someone whose heart really is perhaps starting to get a little bit to the end stage. I just wondered what advice you might give when someone sort of tried lots of different medications, tried the Lasix, and is starting to become a little bit, as a GP, not sure quite where to go from there.
Right. So I guess we're talking about a patient who is at the end stage of their life. Is that what I'm hearing? Is
Well,
that right?
I think, you know, starting to head that way, probably not palliative, but
Right.
for
Okay.
example,
So I guess the
not
big things.
responding as well.
Yeah, so I think the big things are the symptoms of congestion is really what the issue there is, what you're probably alluding to. We have a thing where we like to use probably all three groups of diuretics because we call this process sequential nephron blocking. So as you can imagine that if we just give loop diuretics such as furosemide, there is a loophole somewhere else where the actual urine can be held back. And so by doing what we call sequential nephron blocking, we can block the different parts of the nephron tubule and therefore improve the actual diuresis of the patient. We find that there's a couple of issues. One is that if, for instance, if they have a lot of leg edema and the belly's swollen, the gut is generally swollen as well. So sometimes oral doses of Lasix doesn't really cut it because they're not going to absorb that much at all. We find that sometimes by giving diuretics, perhaps small doses in all three groups, is actually better than doubling and doubling and doubling doses of Lasix in the long term, so long as you've got blood pressure room to play with in that way as well. I don't mind if the beta blockers or the ACE or ARBs are pulled back a little bit to provide a bit more blood pressure because you cannot make urine without blood pressure. So if you can pull that back a bit, so if your primary aim for the next few days is to get fluid off you, then it is okay to pull those guys off for a moment or two and then add some more diuretics to their mixture to get their fluid back off, and then put those other prognostically advantageous drugs back on after that.
Thank you very much. So there's been no questions in the chat, but I'll keep monitoring in case anything comes in. But thank you very much, James. I'm now going to move on to introduce our next presenter, so I'm going to introduce Alistair Miller, who's going to be talking about managing exacerbations of COPD in general practice. Alistair is a respiratory physician working at the Royal Melbourne Hospital and Peter MacCallum Cancer Centre in Melbourne, where he provides both inpatient and outpatient services. He has a strong interest in smoking-related lung disease and streamlining access to care. He is the clinical lead for the North Western Melbourne COVID and Care Pathway and sits on the primary and chronic care panel of the National COVID-19 Clinical Evidence Task Force and on the committee of the Victorian branch of the Thoracic Society of Australia and New Zealand. So I would say you're very busy at the moment, Alistair, so thank you for joining us. But I will hand over to you now to talk about exacerbations of COPD. Thank you.
Thanks very much, Sarah. All right. So as Sarah said, I'll speak for the next 20 minutes or so about managing COPD in the community. And very similar to James, we know that the vast majority of COPD is managed not in tertiary hospitals, but in the community. So look, I'll talk briefly about a background on COPD, about how we assess COPD and treat stable disease, but spend much of the time talking about exacerbations and how we might keep people out of hospital, both in standard therapy, but also what we might change coming forward. So what is COPD? We know that COPD is a common preventable syndrome that is supported by testing showing airflow limitation. And we know that airflow limitation is progressive and it's due to varying amounts of airways disease and alveolar abnormalities. We know that it's related to exposures over long periods of time to gases and noxious particles. And at least for some people, there's a very significant contribution of extrapulmonary components adding to severity. One of the difficulties we have is that it's pretty hard to pin down as a disease. We know worldwide it contributes very significantly to mortality. In 2019, it was responsible for over 3 million deaths, and about 2/3 of these are in low and middle income countries. We know it's very common as a presentation to GPs, perhaps up to about 20% of presentations to GPs are respiratory in nature. We know that it's not evenly spread across the population with an age-dependent rise. And we also know that it's not spread evenly across geography either, with changes depending on where you live, but also quite a marked disparity between the lowest and highest quintile of socioeconomic status. In 2018, it was the 5th leading cause of death in Australia, being responsible for just over 7,000 deaths, with now a pretty equal distribution between men and women. And we know that our Indigenous population have at least a 2-fold increase in rates of COPD as related to the non-Indigenous population. As I mentioned, comorbidity is often a contributor to severity, and it's associated with a number of comorbidities. It's been suggested that up to 90% of those with COPD have some significant comorbidity. There are various estimates of how frequently COPD is associated with heart failure, and somewhere between 20 and 30% of the population is pretty common. And it's perhaps about 10-fold higher than in the general population. But it's not just heart disease. We know that it's associated with type 2 diabetes, perhaps unsurprisingly with lung cancer, given the shared risk factors, but also osteoporosis. And we know that osteoporosis contributes significantly to morbidity in these folk. And it's important because we know that people with COPD often die of other diseases. This is from a meta-analysis a few years ago, and we see that even in people who have quite severe disease with FEV1s below 1.5 litres, that a significant proportion of people are dying not of respiratory disease, but of cardiovascular disease and cancer. We know that mood disorder is really very common, and the number of studies showing that psychological distress is much higher in individuals with COPD than matched individuals without. So how do we make a diagnosis? We're very lucky in Australia, like with the Cardiac Society guidelines, there's an OPDX plan put out in conjunction or together between the Lung Foundation of Australia and the Thoracic Society of Australia, New Zealand. And it's published online with updates generally every quarter. And so this COPDX stands for case finding and confirmed diagnosis, optimizing function, preventing deterioration, developing a support network, and managing exacerbations. So clearly understanding how to diagnose COPD is fairly important in looking at the management. No one would be surprised to know that certainly in our population, smoking accounts for the vast majority of disease. But it's difficult to predict which smokers are going to develop clinically significant COPD. We know about half all smokers develop some degree of airflow limitation, but only 10 or 20% develops clinically significant disease. And we know that deaths from COPD have fallen in line with reductions in smoking rates. But we have to remember, although we should be rightly proud of the improvements in smoking rates in Australia, we have to extend that graph uncomfortably high to show the smoking rates in Aboriginal and Torres Strait Islanders. But outside smoking, and certainly in other parts of the world, there are other risk factors. And we know that any dusts and fumes over a long enough period can cause COPD. Certainly in East Asia and the Pacific, smoke from cooking fires is a significant and important risk factor. We know there are some genetic factors, but it's really only a couple of %. And having bronchial hyperreactivity and mucus hypersecretion is also increases your risk of having COPD. So the C in the COPDX is case finding and confirming the diagnosis. And clearly having an appropriate clinical situation is important. The primary symptoms, very similar in fact to heart failure, are of breathlessness, cough and chest tightness. But really the crux of the diagnosis is spirometry. And while FEV1 as a % predicted has been for many years the main distinguisher of severity of disease, it's increasingly recognised that it's not just the FEV1 that determines the severity of people's disease. And there's been a very large interest in treatable traits across all respiratory diseases, including COPD, looking at different aspects of people's presentation and phenotyping according to those rather than just FEV1. And we know that symptoms increase and function reduces as severity increases. Management of stable disease is very well described by this Lung Foundation stepwise management chart. And I think that really the key things that early on, really from the time of first diagnosis, we need to be looking out for comorbidities. Referring to pulmonary rehabilitation early in the disease is always worthwhile. We know that it leads to increased understanding of disease, improved quality of life, reduces exacerbations, and increases the chance that people are able to self-manage. Unlike cardiac failure, we really don't have any medications that have a mortality benefit. The only intervention, there are only really 2 interventions that do have a mortality benefit. And the first one is smoking cessation. And so smoking cessation has to be upfront in all consultations in people who have COPD. The rest of our pharmacotherapy is really about symptom relief. And so in people who have mild disease with only intermittent symptoms, then all that's required is short-acting bronchodilators, particularly Ventolin. As symptoms get more significant, long-acting bronchodilators, either the long-acting antimuscarinics or the long-acting beta agonists, are really first line. And there are now a number of combinations of bronchodilators. Inhaled corticosteroids do have a role, but it's really only in people who have moderately severe disease, FEV1 of less than 50%, and who have frequent exacerbations, so 2 or more exacerbations a year. Those who have a peripheral blood eosinophilia have also been shown to do better with inhaled corticosteroids, but we know that they come with problems, that they come with risks, and the particular one is an increased risk of pneumonia. So there are now really a dizzying array of inhalers for COPD and asthma, which is really quite different than not too many years ago. And in fact, there's now a second triple inhaler that's just come onto the market. And to be fair, there's not a great deal of evidence to separate one from another. They all come with their own different kind of device, different delivery method, and so it's a lot to do with patient preference. There are a number of other therapies, but I guess the other ones of most note are oxygen therapy. This is the second intervention that has a mortality benefit for those who are severely hypoxic. And I think it's also important that if we're thinking about oxygen, we think about palliative care. And this is really crucial in people who have severe disease. The right heart failure or cor pulmonale we see with COPD doesn't have any specific therapies except for diuresis. And there is increasing evidence looking at bronchoscopic therapies in addition to surgical therapies in a very selected group of people with severe disease. So moving on to exacerbations, and I guess, why is it that we're interested in exacerbations? We know that in addition to the acute episode, they do have an impact on ongoing disease with acceleration of lung function decline. They have a big impact on symptoms and a massively negative impact on quality of life. We know that both during the exacerbation, but also in the year afterwards, there's high rates of mortality. And like heart failure, a huge amount of the economic cost of COPD is bound up in exacerbations, both in the community and in hospital. The difficulty is, of course, that there's not really a single unifying diagnosis or definition of exacerbations. And this is pulled from a paper actually that was just published today, looking at all the different definitions. And you can see that you don't need to read this, but you can just, look by the size of the descriptions that each of these is different. So the definition put together by the COPDX guideline is that exacerbation is a change in the patient's baseline dyspnea, cough, and or sputum that is beyond normal day-to-day variation, is acute in onset, and may warrant a change in their regular medication or hospital admission. And it's really just worsening of the common symptoms that we see. So an increase in breathlessness, an increase in sputum purulence and volume. We know that people with chronic bronchitis have a chronic productive cough, and so it's really about a change in that sputum. We know that having an exacerbation in the past puts you at more risk of having ones in the future. And importantly, we know that people who present with an exacerbation, in about 2/3 of the cases, don't have a formal diagnosis of COPD prior. About half exacerbations are caused by respiratory infections, perhaps half to 3/4, and probably a fairly even spread between bacterial and viral infections. And it's generally the common respiratory pathogens, with Pseudomonas and Staph becoming more common in people who have advanced disease and who've had multiple courses of antibiotics in hospital. But equally, we know that there's a high rate of non-infectious causes for exacerbations, and these are also mimics, I guess, of exacerbations. We know that pulmonary embolism is not uncommon. We know that environmental pollution can certainly cause it, and we have seen that at times of bushfires. We know that heart failure can also cause an exacerbation of COPD, and clearly many of these people are at risk of pneumothorax, which can also exacerbate their symptoms. I don't want to dwell too much on this. This is core business for you guys, but I guess the important thing is looking for symptoms and signs of the differential diagnosis. Clearly, being able to separate whether this is an exacerbation of heart failure or an exacerbation of COPD is crucial, because the treatments are very different. So in the case of an exacerbation of COPD, what is the initial treatment? And really, the mainstay of therapy is bronchodilators and corticosteroids. We know that short-acting beta agonists are very effective. We know that puffer and spacer is at least as efficacious as a nebulizer, but you do need to have quite a high dose, and so it does need to be through a spacer. There are concerns about nebulizers and certainly may increase side effects as well. The evidence for adding ipratropium in the context of an acute exacerbation is a bit mixed, but if it's available, it's usually given. We know that commencing systemic corticosteroids early in the course of an exacerbation does reduce treatment failure and the need for hospitalisation. There's no single dose that's right, but most evidence uses, or most trials use, between 30 and 40 milligrams of prednisolone. And most recent evidence is that very few people need more than 5 days. I generally use 37.5 milligrams because it's just easy. It's a tablet and a half. And we know that there's no great advantage of using IV over oral, except perhaps for that first dose and the speed of onset. So how about antibiotics? We know, if you ask our ID colleagues, no one should be getting antibiotics. And we know that for people who have all 3 symptoms, increasing breathlessness, increasing volume and purulence of sputum, many of these will benefit. And it's probably, in fact, sputum purulence that is the most important. And a couple of trials suggesting that CRP, with a cutoff of about 40, people are more likely to do better with antibiotics than without. The therapeutic guidelines, interestingly, only has an oral suggestion for COPD exacerbations, either amoxicillin or doxycycline. And this is appropriate for the vast majority of people unless you know they have a resistant bug. So who can't stay in the community? The number one reason is that appropriate therapy has been tried and has been unsuccessful. And similar to James's discussion in people with heart failure, if people are unable to manage at home because of their breathlessness, unable to sleep, unable to eat or mobilise, if they have confusion, if they have other comorbidities or new arrhythmia, then clearly they need to be in hospital. And I guess, we need to think about what we can add in hospital. We often will use IV antibiotics. We generally only use oral prednisolone. And so it's really about oxygen therapy and then non-invasive or invasive ventilation. And so if we're able to start the same therapies early in the course of an exacerbation, we can usually or often keep people out of hospital. So having a management plan, helping people understand their disease and understand when it's appropriate to start these therapies is really crucial in managing this. There is some evidence that involvement of specialist respiratory nurses, like we have in HARP, early in the course of an exacerbation enables safe care at home. There's a possible role for the management of right heart failure with IV diuresis by HIF, and certainly we often are able to get people out of hospital more quickly when they require that. And I guess the final thing is just to consider alternatives if the treatment's not working. As I said, most people don't need more than 5 days of prednisolone. And if they do, then we need to be sure that that's what we're treating. So over the last couple of months, we've built into our medical record a management plan for COPD. So it's modelled on the Lung Foundation action plan. So I guess is readily repeatable in the community, and starts with a description of the patient's disease, their usual medications, and then in a stepwise fashion through increases in the intensity of their medication use to the point of needing hospitalisation. We've also got aiming to have a standardised description of their baseline weight and oxygen saturations and baseline basic bloods. So, no talk these days would be complete without a discussion about AI, and COPD is no different. So a group in Australia recently published suggesting that they have an app which was initially used for voice recognition that can pick up on cough features and describe whether it's likely to be an exacerbation of COPD or not. So there's much more coming. So just to finish off, so COPD is a serious and major health problem. We know that exacerbations are bad, both in terms of acute mortality, but also ongoing morbidity. We know that early therapy with bronchodilators and corticosteroids may reduce hospitalisation, and involving respiratory nurses can help with keeping people at home. That's all I've got for now. Thank you.
Thank you very much, Alistair. So once again, if anyone has any questions, please do put it in the chat. Obviously we will ask that. We've got some time for questions now. Alistair, I'm always very interested. I feel comfortable stepping up for that first level of perhaps the 5 days of steroids and looking at inhalers. But I find sometimes it can be difficult to step back down again afterwards. And so you keep stepping up. Obviously, I'm going to take to heart your point. Maybe I should be thinking about other things. But have you got any tips for when perhaps that as the exacerbation, you've kept somebody at home, you're managing in community, but that idea of stepping up and stepping down, because I often find that a little bit of a challenge to get the down.
Yeah, Sarah, it's a really good point. And I think part of it is about helping people to understand the pathology. And while we can switch off that acute inflammation, the effect of that is going to last for probably weeks afterwards for people with significant COPD. And so, having that 5 days is enough to switch things off, but it's not enough to get them back to their baseline. And so setting up that expectation early that people's symptoms are likely not to be back to their baseline for a number of weeks afterwards, but remaining on those medications puts them at risk of more side effects. And we know that corticosteroids are a great medication, but beyond a couple of days, they really do have significant side effects. They really impact on sleep. They cause quite significant fluid retention. And the commonest thing people report is swelling in their face, swelling in their ankles, and obviously long-term effects on bone health and so forth are significant as well. So I think unfortunately it's about setting expectations, and perhaps you can use the puffers to escalate the dose of bronchodilators or indeed inhaled corticosteroids for a short period as well. The evidence is less good in COPD than it is in the asthma space, but certainly there's very little harm in doubling the dose of your inhaler for a short period. So if they're on a combination inhaler, having 2 puffs 3 times a day rather than 2 puffs twice a day, or indeed 3 puffs or 4 puffs twice a day.
Thank you, Alistair. We did have a very similar question in our chat, so I hope that did answer it, about how do we talk to a patient who's reluctant to step down, and I think you covered that. Side effects, perhaps we can negotiate puffers, but I think that might be also a role for motivational counselling and goals, which hopefully we'll talk a little bit more about with our community team as well. So, for the person who put that in the chat, if that hasn't answered the question, please put it back in again. We've had a question, is there any guidance, advice on number of oral steroids, short courses per calendar year that you can use before stepping up treatment?
Now, look, it's a really good question, and I think if you have more than 2 in a year, then providing they have severe disease, and I guess if they have very mild disease, then we need to be sure that the diagnosis is right. One thing that I didn't talk too much about is the crossover between asthma and COPD, and certainly if people are needing a lot of steroid, then making sure that they don't have a significant bronchodilator response. So really, a bronchodilator response of more than perhaps 400 mils might suggest that there's both asthma and COPD present, which might mean that in fact inhaled corticosteroids are the right thing for that person to be on, even if their level of obstruction isn't particularly high.
Thank you. We don't have any more questions in the chat, but I might just pause for a moment to see, before we move on to talk about the pilot in more detail, if anyone, last chance, if there was any questions for James or Alistair now, please do put them in the chat. But if there are no questions in a moment, I know that typing on Zoom, it can take a little while for it to come up, but then we might move on when I'll talk about the GP's role and introduce the pilot and our role in that. So I will get my slides up just to give everyone one more moment. And Sue, I'll just ask just to let me know that that's showing okay. If you could just let me know.
Yeah, that's all good, sir.
Thank you very much, Alistair. I appreciate it. You always hope that your slides are showing. All right. Well, thank you very much. There's been no other chat. So I'm going to move on, and I'm going to outline the dyspnea pilot study pathway, as well as touching on the GP role. And at the end, I will introduce a fictional patient to sort of hopefully use that to explain how we move through the pathway, and also to bring in on a panel to hear from some of our community members from HARP, Merry Health, and I'll introduce them at that point in time. So I'm just going to outline the pilot. As you have heard, it is the pathway has been a suggestion from the collaboration between the North West Primary Health Network, Merry Health, Co-Health, and Royal Melbourne Hospital. And the reason that came about is, I think you can hear from what Alistair and James said, and I know from my own experience, that there's an identified group of patients that's frequently readmitted to Melbourne Health for potentially preventable conditions. And I think James outlined quite clearly how that can really impact on someone being admitted, and what we can trying to aim to keep the appropriate people in the community. The most common of these conditions that are often frequently readmissions are heart failure and COPD. So a solution was proposed to pilot a new model of care that better links existing pathways between Melbourne Health and primary and community care. And that was to build on the capacity of GPs to manage the patients, to build on the work that we're doing with chronic care, to try and help that either through in helping us upskill in these areas like what we've done today in the webinar, but also to perhaps improve networks, communication, and pathways for advice and escalation. But the pilot also enables access to a community navigator to provide psychosocial supports and assessments that will help drive better clinical and social outcomes. Hopefully we'll hear a bit more about that in our case. So the core aims of the pilot is to reduce readmissions to Melbourne Health and to reduce the length of stay for this group of patients over a one-year period. It's also to identify and facilitate provision of the health and support services that patients might require to stay in the community. And as we talked about with the community navigator and other parts of the pilot, it's to provide in action a detailed psychosocial needs assessment, and also referrals and support to access some of those psychosocial supports, and overall to improve the patient experience. So what will it do? So the pathway will create better links between existing Royal Melbourne Health and primary and community care services. We will provide education, information, and you saw the discharge summary that Alistair was explaining in his talk, and I'll talk a little bit more about that, but with enhanced discharge summaries to aid decision-making and to aid care in the community. And it will enable access to the psychosocial supports, as I've said. So this is quite a large flow chart, but this information can be accessed on the both the collaborative and the North Western Primary Health Network web pages, and there is GP information that has these flow charts, has case studies to explain how this might happen. So I do want to show it because I think it does give the flow, but if you'd like to look at it in more details, there are ways to access it. So the way patients will be identified for the pilot is that eligible patients will be identified during their hospital or HIF admission, and they will have a diagnosis of heart failure or COPD, with dyspnea being one of their clinical concerns. The patient does need to live in the Melbourne, Moonee Valley, Moreland or Yarra local government areas and had at least one previous admission in 12 months and is at risk of readmission. And one of the exclusions is not currently undergoing dialysis. When that patient is identified, they will be obviously given informed consent to be in the pilot, and then they'll be enrolled into the program. And when the patient's discharged to the community, or if going through a heart program, when the patient is ready to go back to the GP and the navigators, then they will be put onto the dyspnea pathway pilot. When the patient's discharged, the GP will receive notification, will also provide support, education and resources to the GP, including health pathways, which I'm a clinical editor of, and I will talk about a little bit more in the case study. And that patient will be then managed by the GP. The GP is still the person who is taking responsibility and is the home care for that person. But there are clear escalation pathways to medium and high intensity management when required, as well as having extra information to sort of help make some of those clinical decisions that we've talked about. At the same time, the navigator will receive the referral from the discharge, and there will be communication between the GPs and the navigators. So the community navigators will provide a holistic assessment of client needs. I've mentioned motivational interviewing. I'm a big fan. They'll provide techniques to identify goals and barriers. And it may be that there's referral out to services or linkages with services, perhaps transition or facilitation as required. There'll be regular reviews and regular communication with the client's GP. When the patient is in the pathway, there's low intensity pathways, medium intensity pathways, and high intensity pathways, because as we've talked about today, one of the things to help upskill GPs and support us to care for our patients in the community is having very clear escalation pathways. And both Alistair and James have identified when patients might need escalation up to a medium or a high intensity. And so this pilot actually has very clear escalation pathways, which I will go through on the next slide. But when the patient is in the low intensity pathway, then we're going to continue managing patients in the community with the skills that we have for our chronic care plans and chronic care reviews. There will be some advice and support from physicians available if needed. And there will also be patient education and self-management through the health pathways to help with making sure that if we do find areas that we want some extra advice, there's ways of accessing that. And many of the admissions often came from some of the condition-specific escalations, so perhaps anxiety or social changes or changes in roles. And so that's where hopefully the community navigators will be working very closely with us when someone's in a low intensity pathway. So that's outlined here. And how are we going to manage that? Well, as said, we'll get enhanced discharge summaries from the Royal Melbourne Hospital, which will contain further information about medication, especially those things that often are helpful on discharge summaries, such as if there's a short-term medication or a medication that's been held and then has to be restarted again, or medication that might need to be monitored. There'll also be more observations such as weight on discharge, baseline sort of breathlessness or oxygen saturation, also goals to help with the care at home. So what are the goals for the ongoing management, as well as perhaps advice if things start to change, what are some steps that can be put in? There is access to secondary consultation advice with general medical physicians with a telephone line that will be available between 8 and 8. And of course, there's the information that I've talked about both on the websites and through health pathways. So what if a patient does have an exacerbation? How can these patients who are on the pilot be escalated? Well, if the patients have the symptoms as outlined in some of the talks tonight about increasing shortness of breath, increase in weight, difficulty sleeping or dizziness, then there are a couple of options that the GP has. The first one is that they can call the helpline, the call to the general med physicians that are available between 8 and 8, and to get advice to perhaps help with the exacerbation and perhaps keep the person at home. Or there can be a direct referral to HIF if the patient's requiring HIF services, or the patient can refer to HARP for short to medium term support, such as physiotherapy or rehabilitation programs. Or if the patient has has worsening symptoms, some of those symptoms we talked about, like worsening oxygen saturations, high fever, confusion, or hematemesis, heme in the blood, in the phlegm, or a hemoptysis, then of course there is always the option to call ambulance and refer directly to the hospital. So that's this outline there further. So the expected outcomes of the pilot is, if it's successful, the key outcomes will be the improved patient experience, reduced readmissions to the Royal Melbourne Hospital, reduced length of stay, and identification of health and support to help the GPs and the patients to keep the patients managing their exacerbations, managing their care at home. And these flow charts, as well as case studies and further information, can be found on the web pages, as I've said. So I'll just pause there in case there's any questions around the pilot itself. But I am going to introduce the fictional Mrs. M in a moment, as well as invite our panelists to come on board to talk about how this might work with a patient to illustrate the journey. But if there's any questions, please do put them in the chat. I always have to remember to give people time to type. I know that often it can take me a little while to type in any comments that I want. So I'll just give you a little bit longer, and then I'm going to ask my panelists to perhaps turn on their cameras, and I'll introduce them. So one of the questions we've had, and I may actually have to throw to Sue, who is heading up to this, is what are the patient numbers that you're expecting to be recruited onto the pathway? Sue, are you with us? You were having some computer issues, but I wonder if you're available to answer that question.
I am. I'm so sorry. I just completely froze before when you asked. I couldn't get my mute button off. It's always the way. Well, as you mentioned, that there are some capacity limits with the navigators initially, and that's because this is a new position that we haven't trialled before in this way. There have been some navigators sitting in community health that do slightly different sort of remit. And so what we are aiming for is to just take on 15 patients per month initially, and that's to really test the navigator capacity. What we've worked out with them, we're going to monitor that and see, and if there are, we've got a pretty flexible group of people working on this. So if we're way under and navigators can take more, it's easy to liaise with our HARP colleagues who are doing the actual enrolment of patients, either through well, they're doing the enrolment process, so it's easy to liaise with them and increase or decrease the numbers if they're either overwhelmed or find themselves with extra time. But we're aiming for 15 per month.
Thank you very much, Sue. So there's been no other questions, so I might introduce the panel. So I'm hoping you're out there, and I'm hoping that cameras will come on, but I'd like to introduce Anna Maywood, who's the Clinical Lead Care Coordinator at HARP at Royal Melbourne Hospital. Peter Price, who's the Team Leader of HARP Cardiorespiratory Heart Complex Care at Mary Health. And Adam, I'm sorry, I think I'm about to mangle your last name. Adam Dermatel, who's the manager at the Active and Healthy Aging, Aged and Primary Care. So if you are with us, if you'd like to turn on your cameras, and Alistair and James, thank you, you're still here. And it may be that we do find that in the discussion that we do want to ask you about that escalation. We'll see what happens to Mrs. M in a moment. So I'm going to introduce Mrs. M, who uses the pronoun she, her, and she's 84 years old, and she lives alone in an independent living village in a small unit, and she has no family nearby. She does participate in some of the activities at the village, and she has a regular GP who has known her for some time, comes to visit at the village, has a little clinic there, but Mrs. M's able to get to the clinic if needed, if she needs to see her GP before that sort of general once a month checkup that happens. So Mrs. M has a history of irritable bowel syndrome. She's got reflux esophagitis. She gets recurrent UTIs. She has heart failure and COPD, and she has had anxiety. She's currently on Asmol, furosemide, Panadol Osteo, perhixaline, and mirtazapine. And she's had increasing shortness of breath, and she's had variable peripheral edema over the last 3 months, which has been treated with her furosemide on and off. And so it comes and goes and normally is managed in community. She's a bit breathless in her exercise class, but she can walk on flat ground without symptoms. And so that's kind of her baseline at the moment. Unfortunately, Mrs. M was recently in hospital with pneumonia because there was an exacerbation of the COPD and heart failure that was difficult to manage in the community. And she improves and she's ready to be discharged home. And she was identified as an eligible patient for the dyspnoea pathway. She'd had the admission, she lived in the right place. Possibly she might have been at risk because of her social situations, or maybe that baseline that was just sort of grumbling along. And she was enrolled in the pathway and discharged back to her regular GP. And she was discharged with an enhanced discharge plan, which had GP and the GP information from the primary health network. So at the moment, she's on currently the low intensity pathway, and her GP is using general practice care that includes medication reviews, mental health reviews, and chronic condition care plans. And there's also health pathways, which, as I said, I'm a clinical editor, which is available as a clinical resource. And that's been highlighted in the information that comes out in the pathway. And so that has been, respiratory has been recently updated, includes information from the COPDX guidelines. And it's set out in a way to help with assessment, management and referral options as needed, and includes links to things like care plans, the care plans, say, for asthma or COPD, coming from the Lung Foundation. But it also has that picture that Alistair showed of all the different inhalers. It's often got patient information about inhalers to help with medication. And so that is a resource that can be used to support care in the low intensity pathway if you haven't seen it before. And it's got many, many, many pathways which often link to each other. There is a dyspnea one, a heart failure one, and the COPD. There's a range there. And so if you haven't accessed that before, there you can see the website there and the username and password. But you can also, if you don't have the username or password, you can contact Health Pathways through the Contact Us if you go to just Google Health Pathways Melbourne, we're able to help you with access. So that's there and available. But Adam, I might put you on the spot now and ask if you wouldn't mind, because I have felt a bit guilty talking about you without being part of your community. So I was just wondering if you might put you on the spot and say, Mrs. M's on the low intensity pathway and she's been referred to community navigators, and how would you go forward with this?
Yeah, sure. Thanks, Sarah. You did. I think you did sum it up pretty well before. Actually, I think you gave a really good account and background of what a community navigator does do. So, look, in this case for Mrs. M, and to paint a bit of a picture, when the referral would come through to the community navigator, one of the first things that the community navigator would do would be to conduct a comprehensive psychosocial assessment, and and as part of that, identify what are the key goals and what are the key actions and timeframes or timelines we can put on those goals. In terms of connection with the GP in this pathway as well, the navigator would typically then devise a GP letter outlining the findings from the initial psychosocial assessment. But I guess for specifics around Mrs. M, the types of things that a navigator would look at would be, I think, firstly around the physical side, the physical health side of things. I think one of the things a navigator could do is get in and potentially get down to the residential village and have a look at or work with and support Mrs. M with providing that support around the breathlessness she's experiencing in that exercise program. So it might be actually working with the exercise leader around understanding what those sort of limitations might look like for Mrs. M. Being a community health service as well and having access to allied health services, one option for the community navigator might be to actually link Mrs. M into an exercise physiologist or physiotherapist as well for some additional support. The other things that are probably a little bit, I suppose, non-health that come up as well would be, and one thing that we've seen a lot of in the COVID period is upskilling around technology use. And potentially the use of telehealth, and that potentially opening up doors to different programs as well. So thinking about making sure Mrs. M's health access and non-health access is COVID safe. And there's also things like the friendly visitor program that can be that's a volunteer-based program. Targeted regular visits for those who are quite socially isolated, and that's something that the community navigator might look at connecting Mrs. M with also. And in terms of the residential village, I think above all else, it'll be about investigating the social programs that potentially are on offer through the village as well, and seeing if they could actually work with Mrs. M to connect her to some of those programs based on the goals, the interests, and the needs that have been found from the psychosocial assessment.
Thanks, Adam. How would that be communicated back to the GP in this pilot program?
Yeah, so I guess it's a good question. I guess one of the things that will happen immediately after the assessment is conducted from the community navigator is, and I know that our community navigators have already put together some templates around this, but it's actually set out a GP letter, or to send out a GP letter to summarise the key findings. If anything changes through the course of care with a community navigator, they will be connecting either via telephone or via letter or email with a GP. But at the end of the intervention, when the goal-directed care plan is reviewed, and we're looking at the effectiveness of the intervention, they'll then do a review letter and send that out to the GP as well, to give them an update on exactly how connected the Mrs. M would be to the community and to the programs that we've tried to link her into.
Thank you. So that's all going well until Mrs. M wakes at night with sudden increase in her shortness of breath again several times over the next 6 weeks. And she finds the increasing shortness of breath worrying, especially as it occurs at night when she feels she has less support. And so Mrs. M has started to withdraw from her social activities because she feels she's too fatigued to attend. Her GP looks at the comprehensive discharge summary that came when Mrs. M was discharged and on the pilot, and has Mrs. M's baseline observations documented. And Mrs. M has gained weight from the discharge, which has been more than 2 kilos in 2 days and hasn't really responded to doubling the Lasix. So you can see, James, I was listening. She's more breathless than was documented on her discharge. So, as I pointed out in the pathway, this is where you might consider escalating. And so her GP can call the general medicine access line to ask about assessment and further management. So before I go into the other options, I might ask perhaps James whether there would be any sort of advice he might be able to give if I called that number between 8 and 8.
Thanks, Sarah. Yeah, I guess the question that I would have is really, is the diagnosis heart failure, number one? And is there any other possibility that it could be Airways disease or something like that going on? But I guess in the scenario of having a patient with heart failure, known systolic dysfunction perhaps, and then gaining weight over the last couple of days, gaining fluid weight, is probably being fluid overloaded. And classically, all the fluid that sort of parks in the belly or legs starts to migrate upwards towards the lung as they become horizontal. It's a fairly clear symptom of orthopnea in that situation. So the thing is that you would have obviously need to give enough sort of diuretic to get that fluid off her. And you can either keep on increasing the actual oral furosemide. The problems with that is sometimes, as we discussed earlier, the actual gut is edematous as the legs are, so absorption is not going to be very, very good at all. So I have a fairly low threshold for getting someone to give them some sort of IV Lasix, even just for a couple of days would be nice to get that on board very quickly, because it will be a therapeutic test in a way that if things do improve, then you really know that you're actually at the right sort of, heading down the right pathway as it is anyway. Sometimes getting a chest X-ray can be helpful, but obviously when they're sort of standing upright, getting a chest X-ray, all the fluid's not in their lungs at that moment, and they're not going to have much edema on their X-rays at that time at all. So that's always a difficult one to say, okay, this person's got a clear X-ray, they can't have heart failure. That's not entirely true in that situation.
Thank you. Alistair, would you add anything if it was you that I was calling at between 8 and 8 on this number?
No, look, I think James has covered it very well. I think, being sure of the diagnosis is clearly the most important thing. And if people aren't responding to standard therapy for the diagnosis we've settled on, then rethinking that early, I think, is important. And I'd agree. I mean, an X-ray and other investigations will sometimes have some benefit in perhaps ruling out other diagnoses. But again, in COPD, the chest X-ray is often pretty normal unless there's something else going on.
Thank you. So the other suggestion was perhaps that a GP could refer to HARP for further patient education and respiratory rehabilitation. Anna, I wondered if you'd like to join and what would happen to a patient that might have been referred to HARP in this case on the pilot pathway?
Yeah, thanks, Sarah. Apologies, let me know if I drop out. My headphones is a battery operated one and I think it's going flat. So I apologise if I disappear. But yeah, so if they were came through to HARP, we would probably liaise with the navigator in this instance, seeing as they've already been in the pathway, and we would just get a bit of an update. We also have access to care coordination, so we wouldn't want to duplicate anything that's already happened. But then we would do an assessment with we've got cardiac and respiratory nurses in our team. So we would get an assessment done. We would ensure that they were cleared for exercise, and then we would be able to enrol them in an education and respiratory rehabilitation program about how to best recognise early signs of exacerbation, and also the benefits of exercise in maintaining their cardiac and respiratory health. And we would support them with regular reviews as well during the time to ensure that they were on a trajectory of recovery, and monitoring that exacerbation as well.
Thank you. And as part of Escalating, it is informing the community navigator re this escalation. Adam, what would happen if this did happen, that GPs taken the advice, tried some of these options, but has also had some reviews with HARP, but perhaps is escalating and starting to feel that it's moving along to the medium or the higher intensity pathway?
Yeah, and again, I guess from a community navigator point of view, we will typically come in at that low intensity sort of pathway or level. So if it was being escalated, we would essentially we would put the I suppose the psychosocial support or needs perhaps temporarily on hold. And as I think Anna just referred to there as well, potentially wait until the medical needs or the exacerbation is under control, and we then receive that communication back from, say, a HARP or Mrs. M's GP that we are okay to continue with potentially providing more of those psychosocial supports if it's deemed needed.
Thank you. So all of those things help to keep Mrs. M on the low intensity pathway. And so she's returned to her regular reviews and with the communication between community navigation and to her GP. So hopefully Mrs. M continues along that way for the rest of her time. That's the end of Mrs. M, but we do have our panel here and you are welcome to ask us any questions. If anyone would like to put in the chat, or if anyone from the panel had anything they would like to add, maybe not about Mrs. M or about the pilot pathway, we're very happy to take questions. So one of the questions is just for you, Anna, and I'm not sure if Peter's with us or not, but how would you enrol someone on the pilot pathway from HARP?
Yeah, so obviously we'll have been involved with them. They stay with HARP for sort of anything from a few weeks to a few months and possibly longer, depending on how stable their condition is and how much support they need. And it will be great to have the navigators, because one of the barriers to us discharging is often that psychosocial involvement that, and not necessarily the specialist involvement that we require. So we would identify patients who are medically stable, who are ready to transition out of our program for the medical care that we provide, or support that we provide. And we would then refer those to the navigator and notify the GP at the same time of that referral. So that they can get the information that they require as well. And we would provide a handover to the navigator. We have, as I mentioned earlier, we have care coordinators in our service. So again, we would provide a handover about any psychosocial assessments or referrals that have been made, so that they can continue with the care plan that we've developed for the client.
Thank you, Anna. While we're just waiting for any questions, Alistair, I did notice with your presentation that you had the information that would be coming back to the GP. Is there any other information that might be on the discharge summary? I've obviously mentioned the medication, which is obviously something that GPs are always interested in for lots of changes and baselines and perhaps suggestion. But Alistair, is there anything else that might be on the enhanced discharge summary?
Yeah, look, I guess medications is a really important one, and changes to medications are clearly documented in the discharge summary, and ideally all our patients are also getting a what's called an after visit summary, so I guess a brief summary of their stay in hospital and instructions on discharge, and with that there's a description of changes in medication, and I guess what we would be hoping and certainly encouraging our junior medical staff to do is to describe not only what the changes are, but why the changes are made. And I guess this is important if specific changes have been made because of interactions or particular changes in disease course, then ideally they would be continued rather than reverted back to what the previous medications were.
Thank you. Does anyone else from the panel want to say anything else about the pilot that I haven't covered or would like to share with GPs today?
Just from a heart perspective, one of the other things that we have available to us in heart, talking about medications, is we do have pharmacists that can do home medication reviews in that transition of care from hospital out to the home. So we often have our pharmacists involved just to make sure that patients understand their medications and any changes and plans with those medications. So yeah, we do have access to those. So we may also provide the GPs involved with patients in this pathway with some additional information about what's happened with medications during their stay with us as well.
Thank you. So last call for any questions around the pilot or our roles or how things might run in the pilot pathway. But I think while they've got you here, James and Alistair, one of the participants would just like to ask a clinical question. And they've asked, how do we differentiate between COPD and postural orthostatic tachycardia syndrome?
I might give that one to Alistair to start off with, I think.
Oh, that's very kind of you, James. Look, I think POTS, I think is a really difficult diagnosis to make, and I think I guess the intolerance of being upright and dizziness and breathlessness that can be associated with that is often very difficult to diagnose. And I think if there's a suggestion of that postural dizziness and postural tachycardia, then involving a specialist service, and it probably ideally in somewhere where they're able to do advanced testing is going to be really important. And I think, people who have COPD are often do also have some degree of postural dizziness, related to the hyper expansion of their chest and so forth. But it tends to be, we tend to see POTS in younger people and COPD in older people, although it's obviously not always the case.
Thank you. So there's no more questions that's come through for either extra clinical information while we've got you here or about the pilot pathway. So I might like to move on to say thank you very much to James and Alistair for their excellent presentations tonight, and to Anna and Adam for joining me on the panel. Thank you so much and for explaining your roles further. I would also like to thank all the many people who've contributed expertise, time and resources. I know in the working group there was some fantastic discussions. It was fantastic to work with a multidisciplinary group trying to really talk about what would help the patients and who are at risk of readmitting, to help GPs, help the patient and help each other as a team. So that was a really valuable experience developing this pilot. So it'll be very exciting to see how it goes over the next year. So thank you to the clinical advisory group, the technical advisory group, the collaborative governance groups, and the Northwest Primary Health Network communication team. I'd just like to say, Sue, I'll hand back to you in case there's any further housekeeping that has to be done. And thank you for having me to facilitate tonight.
Thank you so much, Sarah, and thank you so much to James and Alistair and Adam and Anna for being presenters and being on our panel. It's been a great opportunity to hear from you all. I want to give one last plug that it would be great if you could visit the websites that we've developed that has more information about the pilot pathway. We've also, for your information, we have we have rebranded a suite of patient resources on breathlessness that were originally developed by the NHS in the UK. And we've obviously rebranded so that they're not referring patients to services in the UK, not very appropriate. But there's a suite of 8 resources there for patients on some techniques that can help them with their breathlessness, such as, you know, the use of handheld fans and breathing techniques and etc. So as well as suites of information for GPs on the pathway, the slide decks that Sarah mentioned about the patient flows, etc., are all there. So really encourage you to go on there and check it out. But thank you all very much for your time. You're always welcome to get in contact if you have any further questions, and or jump on the website and see what you can find. So it looks like we're finished.